Good afternoon. This is Jason Jones with the Community Technical Assistance Center, and I would like to welcome you to today's webinar, From In-Person to On-Screen, Best Practices in Telemental Health with Children and Adolescents. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noise that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it is not visible, click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion of today's presentation. With that, we are very excited to have with us today Dr. Mary Alvord. Once again, thank you for joining us, and I will pass it along to Dr. Alvord to introduce herself and get us started.
Hello, everyone. I am thrilled to be here, and I will just start with, I am a psychologist, been practicing for 40 years. I also do a lot of training and some research as well. I started if I'll go to that slide, it's not working. All right, let me see. Get it going here, technology. Okay, so I started a nonprofit as well called Resilience Across Borders. And what we do is we provide groups in high poverty schools in DC and Maryland, and we do this with Catholic University, Alvord Baker and Associates, and Resilience Across Borders. So let me see if my up-down goes. Yes, nope, the wrong way. Okay, so conflict of interest. Unfortunately, I never invested in any of the telehealth products, so I've been doing this for a long time. I have written a few books. One is the Resilience Builder program, which is a group curriculum based on the resilience literature as well as CBT strategies. And I have some CDs which are also digitally available. And my latest book is a transdiagnostic workbook for teens on changing thinking habits. So before I go on, just to give you a little bit of background about myself, I actually was born and raised in Queens and went to university in New York, and then came to Maryland to go to grad school and have lived here ever since. I was president of the American Psychological Association, has many divisions, and one of the ones I was president of was media psychology and technology. So technology has been an interest of mine for a very long time, and I have been doing telehealth for 15 years now. I'm getting a little bit of feedback. I think someone is not muted. So it's just for information. And I started doing telehealth really originally when the cameras were not very good, the audio was horrible, but it was a way it was a way to really connect a few offices so that for staff meetings we didn't have to travel to one office or the other. So it was great. Back then we had to use not very good, the visuals were not great, but we could see each other, and then we used a Polycom phone for the audio part of it. So today our goals really are, we're not really going to touch so much on technology because I think that you're going to be getting links where you can find the up-to-date in terms of all the regulations. They are really changing daily in terms of what's acceptable and what's not in terms of technology and consent and that sort of thing. But the focus will be on engaging kids and teens.
Can you put a church in here so I can get my sister a box?
I think I'm hearing something. Connor, it might be that you're not muted. Okay, so, but my priority is going to be engaging therapeutic techniques. I will say at the outset, though I've been doing telehealth for a long time, never before COVID-19 and sequestering have I done it full time at a large practice. There are 18 of us, and we are all finding it more tiring to be in front of a screen all the time and or phone, because I know not all of you are going to be using video technology, but the phone. But as clinicians, I think we thrive on sort of the feedback and that reciprocity and the back and forth. It's more tiring. There's also more preparation, which is why I'm so happy you're joining, because we've been doing this for a month now full time, and we've had to really adapt what we do in person to this new mode. I'm going to talk about groups. That is my love, is running groups, but it's also a way for us to reach more people in need. I feel very strongly that there are just so many more mental health needs than there are providers, and group also gives you a mechanism of having, especially if you have a transdiagnostic perhaps group, but with enough core similarity, people can learn from another. So, for example, if someone is highly socially anxious, but you've got someone else who is, ADHD and talks too much, they can each use the other as a role model in group. And it's also a way to normalize that you are not alone, which is a message we're trying to give all the time for suicide prevention, but for all acceptance of mental health and reducing stigma. And it's translating what we do in person to the virtual work. So, with kids, the message I give in teams is that, we're all learning, we're all adapting, and we all make mistakes. And here's a little girl wrote, like, even princesses make mistakes. I think as clinicians, we also have to do a lot of self-care, and we have to know that we are going to make mistakes, but that we're learning and we're figuring this out. And I think up front, I've been telling a lot of my clients that, I have not done this the whole time. So, let me see. So, why moving forward? I think now that we are 100% either virtual video or telephonic, my hope is that later we use it as our practice did in the past, which as an adjunct for people who couldn't make the session for some reason, intermittent for like shorter check-ins. If you do a 20-minute check-in, it's a lot more efficient to do it, over video or over the phone. Or sometimes we probably 10 to 15% of our practice was already working on telemental health practice. I think as clinicians, we practice and we learn. But even the system today, I'm not used to using this WebEx. It takes a little bit of, each system is a little different. And so I would say practice with your friends, practice with your family, whatever system you're going to use. And if it's using telephone, figure out, maybe think about like how can you do engaging things even with kids on the phone. But it does require more preparation. We have to think through what we're going to do in advance so that we have materials. And I guess before that, let me just show you, I have a bag. So those of you who can see my picture, this is sort of my bag where I have a lot of my standard props that I use, like rubber bands, and I have this turtle, which you'll see later, a Chinese finger trap to show that, if you sometimes try too hard and you get anxious and you get tense, that you're really going to get stuck and you have to relax so that you can think more clearly. So I would say have a little basket or bag or something of props that you're going to use more regularly. And when you work with teens, you may not have some of those same props, but think about what apps you might be using to have the student, the teens work on with you or anything else. So getting started, of course, for some of you, the internet service is going to be difficult and not consistent, or the bandwidth not great enough. So you may be using telephone. I would say if you can use video conferencing, you gain that much dimensionality. You can still have eye contact. You can see them in the whole. And typically, from what the research says, is that video conferencing sessions last longer than phone sessions. So I think whereas some people have done long phone sessions, on average, they're shorter. Equipment that you need kind of on both ends are a webcam or a laptop. Let people know that sometimes frames freeze, so that they expect that there may be some things that come on. The audio from all the research shows that that's really the most critical. So even if you have a picture of somebody, as long as the audio is continuous, that's the most important variable, and that's where the therapy gets done and is so critical. And I have a large monitor that really helps me, especially when I run groups, because then I can see everybody on the monitor. Lighting is important for us. We want it either from the front or the side, not behind. In my other office, I have a window that's the light really comes, so I often have to close the shade because otherwise it takes away. And then always check your video and your speakers and your mic. For not just interstitial, but mostly for safety reasons, you will be probably developing telehealth agreements of some sort and discussing risks and advantages. But you need to note for every session where the person is with whom you're speaking, so that you know, and we'll get into resources, but you know what emergency services are available, where they are, who else might be there in the home, so that if something comes up, and it might not even be an emergency, it might just be a tech issue, but who can you get hold of and how and when. So what are platforms? Your agency may have many choices of platforms, but I think when we're looking at what features do we want in a platform, when we're working with children and teens and families, we want to be able to have encrypted emails so that the privacy is upheld and that we can send information. Some of you may have electronic medical record systems that have portals, and so it can go through that. Another really important feature that I use all the time is screen share to show documents that we're working on, assignments that I've given, because I really work more from a cognitive behavioral perspective, and so that in between assignments are really important. May give worksheets, that way I can show my screen. I make PowerPoints just to illustrate things and share that. We can also share videos and audio recordings. The other, I think, important feature is a whiteboard. So some of the platforms have a whiteboard. Some of them have them, and then the administrator has to enable them. Some of them do not have them, but now Microsoft has a free downloadable whiteboard that is independent of whatever system that you have. I think with all of these, we need to be aware of privacy issues. I just take a picture of the screen and then I email it in a secure email. I am still wary of just sending things, especially if there's any personal health information. I don't want to send it to a cloud that I don't know is not private and safe. The other important thing is if you are going to do groups, many of the platforms, particularly ones that are free, that even large agencies are using really only have the capacity to have one client on the other side. So that may be fine for your purpose. For us, we do a lot of groups. And as I said, I think in order for us to reach more people, that as a mental health community, groups are really the way to go, different kinds of groups to meet different needs, but it's a way to help access more services for more people. So think about whatever system you have, do you have that capacity? A note, there is research on groups that are just done telephonically, and so that's also a possibility to do that. I think that would be very challenging to do with younger kids, and perhaps it would work better with older, that primarily a verbal therapy to do telephonically open, or you can have a combination. And then what security controls do you have? Nowadays, it's getting even more critical. You know, passwords. We use unique IDs for each client and passwords. There are some platforms that have waiting rooms, and I know a hospital here, their psychiatry department is using that feature, so everybody gets a link, and then they go into the waiting room and wait for their appointment, and their psychiatrist or whoever lets them in. But I've heard that that's not there may be some security issues with that. And then, really importantly, when you're doing work with kids is for you to be able to control their video options as well as their audio. I am finding the kids they're just learning faster than I can keep up with them. They have learned now to change their name in the video chat to, Sam the Penguin or something silly, or they're chatting to each other in a group, or they have learned how to not physically move their camera upside down, but to manipulate with controls. And suddenly I'm talking to them and they're upside down. And so we'll talk about sort of setting rules and expectations. But there are features that we may not know about. And so I've taken the tact of, well, that's really interesting. I see that you're doing that. Can you explain how you did that, so that I can learn? The other one they really love too is virtual backgrounds. And so again, they are savvy. They are more the digital natives, and we are the digital immigrants. Another important is recording. That needs to be discussed, because while we have the capacity to record or not record, should always be discussed with a client. If you are recording, they now have the capacity to record with their phone or some other device that we can't even see. So that should be sort of an upfront conversation. Here's just an example that I made up of a meeting. You see this is a Zoom meeting. I made it for today, and the link, actually, the password is embedded in that link. So they would click on that long link, or they have the option of going to Zoom, for example, and putting in the meeting room, and then it will prompt them to put in the password. You've probably heard about Zoom bombing. I think it was large public gatherings that just sent everybody a link, not even with a password, but they made it publicly known, and then people just shared their screen. So as a host, you want to make sure you can also lock the session, so it's just who you're using it with, and you can decide who's going to share the screen or not, but you're going to start with a unique link of some sort. With the phone, it's not so much of an issue, but you do need to find out who else is in there, and is it a private space so that it's not overheard. I think cultural considerations are so critical. I find that even in the Washington, D.C. area, in the New York area, wherever you are, there are communities that have different beliefs about mental health. And now that we're crossing into more areas to through video, or people maybe didn't come in because it was a few hours away. Now people are more likely to seek services because we're breaking down some of those barriers. So more importantly, to know about their community and what does it mean to have a problem or a disorder. Are there AA meetings? Is there some acceptance of some kinds of interventions? What role does the community mental health center play? My first job out of grad school was a community mental health center in a rural area, and back then they didn't even have child and adolescent services. I was sort of brought on to start those services, and I had to visit communities because transportation was very limited for the people. So I actually went out and learned about the communities and what resources they had, what resources they wanted, what was important to them. So I think with telemental health now, our communities are actually expanding into areas, I hope, that have not otherwise accessed mental health. And that's what happened when they discovered, they were a little reluctant about, community mental health center and the child and adolescent services. Just to give you a day, this was in the late 70s, so a long time ago, but there still remains a great deal of stigma, and different communities and different ethnic groups have different stigmas or beliefs. Who's part of the family? What is the configuration of the family? I make no assumptions anymore and just say who is in your family, or who is your caretaker, with whom do you spend most evenings, just so I have a better sense. Some ethnicities are more open and some communities more. So the other thing is language barriers. For so many, English may not be the first language or the primary language spoken at home. And we do know that when people get more upset and emotional, they revert to their primary language. So finding out, what is mostly spoken at home, what languages are they exposed to, what cultures are they exposed to. Again, not to belabor this, but I think cultural considerations are really crucial so we know with whom are we dealing with and how can we best work with them. The other really wonderful thing about telehealth is, as practitioners under ADAA, we must have both sign language interpreters, if that is needed, as well as language interpreters. And it's wonderfully more convenient and less costly to bring in these interpreters or translators via telemental health. So I've worked with families where we have somebody we know, but she's actually about 45 minutes on a good day away. So we bring her in to do sign language with some families, and it doesn't necessarily mean the whole session, but she can be there the whole session, depending on the configuration. We have a family where the child is hearing, the parents are not. So it's wonderful to expand, again, accessibility. So I want to talk a little bit about my frame, which is particularly, I think, appropriate now, is the resilience frame. I always have rubber bands because I use this to demonstrate a lot of different concepts, but it's also easy for kids or teens to have it on the other end. And I do a demo where I say, if you have a rubber band, take a look at your rubber band, and this is something you can do on the phone as well. Stretch your rubber band when you are stressed or you're upset or you have a lot on your mind. See how far it can stretch. And what happens? Well, the rubber band gets really stiff. And this is what happens to your body. When you're stressed, your body, your tensils, your muscles tense up, your body gets really tense, you feel stiff, you can't think as clearly. So our goal is to come up with strategies and so that we can slowly get back to a calmer state, but also one where we're flexible. So this reinforces the concept as well of cognitive flexibility, which we know underlies mental wellness across many different diagnostic categories. If you're cognitively more flexible, then you can think more clearly and you can also problem solve better. I also have, these are called high bounce stretch balls. The kids really like them. It's harder now to do if they may not have that on their end, but we can demonstrate on our end. And the ball, you stretch and you stretch. And again, it symbolizes how stretched they feel. And what do you do for the ball to look more like a ball and round and for it to be able to bounce? You need to come up with ways that you can take care of yourself, calm yourself, think more clearly, and take more action that is healthy as opposed to unhealthy actions and thoughts. And I won't demonstrate, but it does bounce back. So the protective factors that we know, and I think are particularly important now to put in and to teach kids, and you could do this, with a PowerPoint slide that you may share, or just talk about one or two of the protective factors. But, the first being proactive. And what we know from 5 decades of the literature on resilience is that the core of being resilient is being able to believe and know that while you can't control everything, there are many, many aspects of your life that you can control. So I'll show you, because I've been running groups lately, and what we focus on is what can you control, what can you not control, what can you give up. Right now, there's so much uncertainty and things change on a daily basis that we just have to deal with the here and now, and some mindfulness techniques which we can talk about and you can incorporate. But the core is not being reactive, but being proactive, not feeling like a victim, but rather taking charge of just those little things like being able to go outside and take a walk. Scheduling some reading time, scheduling some playtime or downtime. The other factors that we always want to reinforce are self-regulation of mood, of thoughts, and of behavior, attachments, of course, with family or caretakers that are critical to your lives, special talents. So kids now are doing online school. It's around here, it's a small part of the day. But, when we get back to normal, many kids, school just is not something that comes easily or that they do well. So we want to nurture not just the academic aspects, but what are talents that they have. Robert Brooks, who's at Harvard, talks about islands of competence. And that's how we develop our self-esteem. So through the telemental health, you start thinking about what do you do when you're in person? What are your goals? What are the things you're trying to get across? But underlying it should be really increasing these protective factors and helping them develop these talents that they can do now, because we can still order things and have, things delivered to our homes, even if we can't go out so much. The other is proactive parenting, and it doesn't necessarily mean natural parents. It could be caretakers, guardians, whoever is in charge of the adults, of placing limits and consistent rules, but high expectations. But it's all got to be coupled with sort of warmth and acceptance. We, with our younger kids now that we have dealing with, because they're not doing as well, and you really need to think about like what kids, how young, but it's not always just the age, developmental level, what disabilities might be there, who's appropriate for either telephone or telehealth, or is it better to focus on, during this time, parents, because the kids are really needing that structure. They need some routine to the day. They need to incorporate movement and breaks and transitions and all the rest. So for our younger kids, we really have transitioned to more parenting work. We've always done a lot of it, but even more so now for the kids that are just not don't work well with the mental health. And then what's the community support? I think where this comes in, both with attachments and connections, is our work as mental health providers is knowing and reinforcing and making sure people have the connections and the social support in their lives. When we first came up, I don't know who came up with the term social distancing. I felt like that was not a useful term because we really want physical distancing, but we want social connection. And some of the therapy that we're doing, I'm finding, is we're doing more frequent sessions, but perhaps shorter because so many people are finding they're more isolated, and this is a way. And that's part of like building community where people can no longer go to their house of faith or other clubs or kids with sports. So how can we build a community sort of online with people that we really know? So here's where my turtle comes in, being proactive. And I often, with younger kids, maybe have them get a stuffed animal, and lots of teens have stuffed animals too. And we just talk about, so if this turtle is on his or her back or they back, what does it take for them? What can they do to right themselves? And so we focus on what you can control. And well, the turtle actually has a body inside, so it can wriggle and it can move. The turtle also can make noises and it can ask for help. One of the key aspects of being proactive and taking initiative is knowing when you need help and reaching out and asking for help. So it doesn't only build resilience to give help, but it's also to get help when you need it. So think about in your agencies, your hospitals, what services are you providing? What is working now? What we are finding that is not working for us is we're really not able to do full psychological batteries, for example, but we can still do intakes and assessments. The difference now is that we don't have as many of the nonverbal cues. We're not having people seeing them in a waiting room and then getting them. So we're losing some of that, but we can get it. And then what kind of online assessments we give and have actually for a long time used the BASC, which is the Behavior Assessment System for Children. What I really like about it is the age span through age 21. And you can send a link to the parents or guardians, and then you can ask then the child or the teen to do it, but also then they can send a link to the school for a teacher to do it. So we've been able to do, and we have fully pivoted to, we have since I think about the 20th of March, we've had no one come into the office. Everyone has been virtual, and so collateral sessions, and our primary focus has been continuity of services, but now we're getting new calls, also providing a lot of supervision and consultation. And if your agency does a lot of crisis calls, let's think about how can you triage using telehealth. Again, once you're used to this, you just find how rich it is and how you really do feel like people are there, not 100%, but they're there with you and what you can do. Special consideration, I touched on some of this, are the research has not quite kept up. Years ago, there was really very little except the VA, but in the last 5 years or so, a lot more with children. And it's amazing, treating young kids in their home with parent-child interaction therapy. If you're using that, is actually, they're finding, and it makes more sense, is actually more potent, more effective than when it's done in a clinic. Well, why? Because if the problem, so much of the problem behavior is at home, then you're doing it in the natural environment and you can generalize. So think about like there are legal issues, who do you get permission for? In some of our schools, some of the family kids don't live with their parents, they live with somebody else who's custodial, who's going to get permission. But in terms of considerations for you as the clinician, thinking through what equipment do you need, how, what's the room set up for you, and we'll talk about that, different cameras, and the emergency backup situations are absolutely critical. So what if they just slam the laptop shut? They run out of the room. Well, in the office, someone could go after them. There, you really need that plan with all the phone numbers and knowing who's around so that you can get the situation under control. Also, what mobile devices do they have? Do they have smartphones so that they can download apps? Some of the apps that we use are free Virtual Hope Box and Mood Coach are examples for the teams. What's really wonderful about them, they're developed with the VA and the DoD, and they're free, but not only that, they've actually been vetted because there are zillions of apps out there, and we don't really know how effective they are. And just pictures on the bottom, you see, what I have found is the kids are not, although I think they're speaking to me, and they're really good at keeping their eyes sort of on the monitor. They're doing things with their hands and maybe even have a screen behind them and they're playing video games. Or somebody is in the room and we don't know, maybe a dog or a cat, but maybe a sibling or maybe even a parent. And then setting up what are the expectations to attire. And a kid who joined group and said, oh, this is really great because I just got up and I'm in my pajamas. So all those kinds of things are setting expectations that it's got to be the same as in the practice. What I'd encourage is you make your own checklist of like what you need, maybe a child checklist of what you need to have, and then a teen checklist that really be aware of what your visual background is. So today I'm in one of my offices. This was another office, and we sort of messed it up. But you see with kids how distracting all of that background is. And we sometimes need to have them wear headsets, or we need to have headsets. For home, I purchased this 4-panel screen. It's really lovely because I've actually taken over one of my kids' bedrooms and made a little cubby with the screen behind me so that it's more professional looking and they don't have the distractions. But also, someone very cleverly put a white sheet behind because they didn't have a screen, and we're all now at home unexpectedly. So solid covered sheets can also cover, just make sure it's clamped so it doesn't fall in suddenly in the middle. But you don't have to have a screen, but anything, but be aware. So what kind of supplies? Think about what you do in person. Now, not only do we need the supplies on our end, but we also need to guide the parents to what games or supplies do they need. Talk about privacy, being in a space. Sometimes people are in an apartment and there is no private space, and even if they put earbuds in, you can't, the other people there may not be able to hear the clinician, but they could still hear the talking. I ask, can you go outside? But that means they may have to have a smartphone or a phone that extends. So just be aware everybody's situations are different and they just may not have as much privacy. Sometimes you actually want to include the parent in the session to help guide and actually coach the parents and teach the parents. We do that a lot where we're actually teaching the parents the same skills that we teach the children. So different games. And integrate movement breaks. So one thing I do is in the middle of the session, because it's hard also for me to be sitting, usually I would go to the waiting room, I would come back, maybe we go to the toy room and come back, we're just sitting. I like to have them just stand up And I'll stand up to show you sort of in the middle of session, and I just have them pump up on their toes like 5 or 6 or 7 times. It's a movement break. Maybe they can move their arms up, touch their toes. It's also a way for you to see like the whole child and how they move, how fluid are their movements, and pick up on anything else. Scavenger hunts are really wonderful for both phone use and on the video, because, and we'll talk about that a little bit more in detail, but scavenger hunts are movement based, so you can have them, find something in their room or the room that they're in to show you, and you can either guess what it is, or you can do the same, starting with a certain letter, but it's a way also to help them bring something that's maybe they like, that they want to share. And then for our younger groups, what we've had to do is adjust the time. So where they were an hour in person, for the 3rd grade and younger, we've made them 45 minutes and use a lot of videos that we use and different activities. But even so, when we were in person, we had game time, and some of that took up time. So, and in the phone, all the ways that you can engage them to do things. So consider the type of therapy that you're doing and guiding the parents. I think the silver lining in this is that hopefully more people will use telemental health and more in the home, so that we can really guide the parents and the teens and recognize perhaps what the triggers are. I do a lot of work with OCD, and some of the triggers are in the home, and so we can actually do exposures in the home where it's most meaningful, and it's just one step less to generalize. Here are some really great games, particularly if it's individual. Battleship, if you have one part of the battleship and they have the other, is a great game, because that's what you would do in person anyway. You each have your own little thing. Guess Who is another one like that. And of course, for cards are always, most people have cards, are easy to access, and you can do a lot of card games. What we do, part of the teaching the resilience skills, we have kids make remote controls, because we're really trying to get them, and these are just some ideas to engage them. So, with art supplies, file folder, whatever kind of paper, we can really give them the message that you can change sort of what you think. You can change, if something is hard, you can say, this is really hard, I'm so stupid, I can't do this, rip up the paper, or this is really hard, but something else was really hard. I didn't used to be able to read chapter books, and now I can read chapter books, and I can try, and I can ask for help, and so that's the I can. And linking the thoughts to, we can change to different channels in our mind, and therefore make a remote control. And we can go to a happier place, a calm place, a proud place, and then really teach them the links between what are the thoughts, what are the feelings, and then what are they going to do. So, the teens may not want to make a remote, but I have found they really love using the whiteboard. I'm going to keep track of time here. And here's another for younger kids. We create a file folder, and most people have file folders at home and pieces of paper, and we show that you can change the channels in your mind, and so it looks different, it feels different, and you have the opportunity, and you're empowered to change those. So you can make lots of pages during different sessions, and they can do it on the phone, or they can do it over video. With teens, decide, do you need a check-in with parents? I use a lot of index cards with teens, because we do a lot of coping thoughts and coping actions. If there's a workbook they're using, so I mentioned the workbook that I wrote, it actually has a free page through New Harbinger where there are worksheets that you can download, and so they can just download them too. You can register and get them, or you can email them. They're just different ways. We do a lot of exposure hierarchies, and we can do that all on the screen. But if you have a phone only, then you can still guide it and they can read it to you, or journals or anything. So here's just, an example. If you use a system, a platform, and many of them that have whiteboards also have you can give control to the other person through remote control, but there's also a feature called Annotate, and I'll show you that, where they can actually write on the form. And I always, like I said, I take a picture of it rather than saving it to the cloud. Just that way I feel like I have more control over it. Here's a really fun activity. I found this is free. I'm sure it's not the only one, but the kids and the teens really love creating avatars. This is where I make a PowerPoint, and then either I can make it and they guide it while I'm sharing the screen. I can put it on here, and then we can, with the annotation, make bubbles and write what they're saying or whatever. So I gave you a couple of examples. Here's a use of a whiteboard. And again, this kid, if you can see, I took a picture of my screen, you can see that they can, right here it doesn't show, but there's the annotation where you give them control and they can write. Kids love it. What's really great, they can do text boxes, they can do shapes, they can change the colors, and they can make the writing thin or fat or however. Something we talk a lot about is cognitive flexibility, and so I don't have spaghetti with me to illustrate, but we talk about, like a pencil, right? A pencil is really stiff. And if you're stiff and you can't think of possibilities, and we want to always encourage problem solving, then if you bend it too hard, it will, and they say, snap. The fun thing is if you used spaghetti, it goes all over the place, and that's something they have at home, and you have with you, or something sharp, and that you can use to illustrate it. So just another way to illustrate a lot of the concepts that we teach and that we work on. And of course, problem solving is, helps us really figure out what are we going to do next. We make books together, and this is something they can do on their end. They can show you the book. They can share a picture of it later, or it's something that you can actually make on a whiteboard together. And here's just an example of something that was on a whiteboard. I took a picture, it didn't work out very well, but it's something that you can do in terms of the feeling and the body and the thoughts. So the format for groups is, of course, this is what it didn't look quite like that, but we sat around, and now we have all these boxes. So the sessions that I recommend now are resilience, being proactive, optimistic thinking, problem solving, stress management, thinking errors, and then also anxiety management. What I do is I mute all the participants, just like you are muted on this webinar, but I give them the control to speak one at a time. But I do relaxation exercises during group. And we have recordings, or I can lead them through progressive muscle relaxation. At that time, I mute everyone. So let's see. For stress management, a really fun activity is getting a bunch of books and saying, like, for small, what are some small stressors or small things that bother them, medium books and high books, and then have them hold it and then talk about how did that feel on their body, where did they feel it. And this, again, you can do this on the phone, or you can do this through a video platform. This is another cute little thing you can use. It's free, word art www.wordart.com, and they can make different shapes with different words, maybe to show how they're feeling now, and then choose the colors and choose the shapes. So here's just one more example of a whiteboard. It's a lot of things, but I use this for group participation. Like, we notice and give them checks for when they speak about their assignment and cooperation, and they get a star if they are leader of that week. And here is somebody drew this, and then we can use shapes and colors, all kinds of lessons. And then for Zoom, what I use, you can also have second pages. So there's this little button over here, and you can go to page 2. So page 1 might be what your, roster of the group and who's doing what. Page 2 might be a topic you're working on. 3 might be some brainstorming solutions. So those are some ideas. I think we're going to open it now to, as an example, again, of pictures, of not invading space. Hangman is another very fun game to do and very easy on the whiteboard. I did it with a group, and they were actually all wanting to take turns, and that was a middle school group. And of course, visualization, relaxation exercises. You can do a mindfulness walk if they can take the phone outside, or they can do it and report it to you later. And exposures, I went over that. Here's a picture of a hierarchy that a little girl did. And again, we can do shapes and colors, and it's just very engaging. So set up your expectations. Think about developmental considerations, your room, what props you want. Have a little bag or a basket. Document why you're doing telehealth. All our notes now say COVID-19 telehealth. And then where they are, and think about incorporating movement and not just talking, and movement as in large muscle movement and not just like artwork and talking. So here's some resources. I think you all will have a copy of these, a PDF, so you can look at that later. And now, Jason, I think questions and answers. I think I went couple minutes over, so sorry.
No, that's fine. Thank you, Dr. Albert. That was great. And we do have a lot of questions coming in. Okay. The first of which is really pertaining to creating structure within the home when working with youth. So one learner said that oftentimes they find that there's no structure created by the caregivers. And what's some messaging that you can have with caregivers with that regard? Because oftentimes the youth are disengaged in playing video games or doing something else.
This is a huge challenge, because at this point, even if you have an intact family and you have both parents working, the parents are trying to do work and the kids are sort of left to their own with not a lot of school or activities. The ones with little kids, it's really, so what I suggest is routines. I suggest the first thing in the morning for the family is, what would you normally do? You would leave the house. So leave the house, walk for 10 minutes, come back, and then do a routine and set a calendar. I think contingency management is probably the best parenting technique we have, and that means you do your work or your chores or what you need to do before you get the fun time. I also think parents have to be kind to themselves, because kids probably are going to be doing more screen time now than before, because they may have a work meeting and kids need to be occupied. But I think especially for older kids, we need to have schedules in place, and intermittent with outdoor time if you're so lucky. I know, sometimes that's hard to do, but just some kind of a movement or a play time. And the choices are, you go outside, or you do a jigsaw puzzle, you do this before any screen time. So routines and structure are important. And what I do is I tell the parents, look, you need to take care of you. What do you need for things to work? What kind of structure? And if you have your oxygen tank on, then, or mask, then you can help your kids with that.
Great, thank you. The next question is with regards to working with groups online. Do you set up agreements beforehand, such as be present or no recording, that you lay out before the start of the group?
Yes. So I actually email the parents in advance and tell them these are some of the rules. The kids need to be in a private space. We have to respect privacy of the group members, just as what we do when we're in person, but it's even more so because they're at home now. People may be coming and going. We talk about the rules of who's in the room or not. We did, like I mentioned in the beginning, no recording, which means they can't use extraneous devices. So the privacy is at the utmost. But in addition, we have rules about when you can talk one at a time. Look for those cues. Look at who has a little yellow frame around. That means they're talking, and somebody else who may be moving forward is talking next. That's all laid out in, but there were things that I didn't anticipate. I didn't anticipate them renaming themselves, Sam the Penguin or Patty the Porcupine, because I didn't know about those features. And so once that did, that's why I use the whiteboard. And so then we put it as expectations. And I have the whiteboard that I use is several pages. So one page is the rules and expectations, and with the kids because something has come up. And then the next is the lesson, and the third one is strategies. That's the way I plan it out, but it needs to be discussed. The other thing is we have a telehealth agreement, and so people are welcome to go to my website for my practice. Under forms, it's alvordbaker.com, and under forms, you'll see what we use for a telehealth agreement. And so we talk about those particularly for groups, because groups are just more vulnerable in terms of the privacy issues.
Sounds good. The next question that we have is with regards to really engaging youth who, for some reason, for a number of reasons, aren't comfortable with being on video. What are some strategies that you have when video just isn't an option?
Well, actually, I press if video is an option, but they're not comfortable with it, I start with them turning their camera off so that they can see me, because I feel like the video, if there's a choice, I always would choose video over telephone. It's not always a choice, but that's a way to have them, or you maybe set up 5 minutes, a 5-minute time where they can just download the equipment. But a lot of times is they don't want you to see them, or they don't want you to see their background. But if they can see me, at least that is better. And then if not, then we would move to telephonic. Something we haven't really had time, or, kids are just more resistant to the talking. And that's why we just try to engage them however we can. If you have a kid in group who just doesn't want to do something, sometimes we end up talking with them, or we give them assignments, or we tell them, I've had a lot of kids like this, and this is what is often on their minds. And just use all our clinical skills. Our clinical skills are still there, but now we're just putting it forth in another medium.
Perfect. Thank you, Dr. Albert. And with that, I do want to thank you for an excellent presentation. We really appreciate it and all of the guidance that you provided.
Thank you. And I just have one more comment in terms of technology. Whatever platform you choose, I would go to their websites, and a lot of them have webinars or just like blogs to find out about the features, because all those features just help us that much more engage teens and kids. Thank you so much. Thank you for joining today.
Awesome. Thank you. And everyone, thank you for joining as well. We do want to remind everyone to visit the CTAC COVID-19 resources page, which is here. It will provide you with updates from the state, tip sheets, other webinars and resources, and really some great guidance with regards to telehealth as well as other resources on COVID-19. So thank you, everyone. Have a great afternoon, and we will see you next time.
Thank you.